This is the audio lecture for Chapter 6, Genetics, Conception, and Fetal Development. Everyone expects a perfect baby, and if a genetic disorder occurs, the shock and grief can be as if the child died, and really, their perfect baby did sort of die. Understand that they will go through stages of grieving, starting with shock and denial, and they really cannot be pushed through these stages. You have to give them time and help them concentrate on immediate needs and very short-term goals until they are ready to start anticipating the future. This lecture presents a brief discussion of genetics and the role of the nurse in genetics. It also provides an overview of the process of fertilization and of development of the normal embryo and fetus. Recent advances in molecular biology and genomics have revolutionized the field of healthcare by providing the tools needed to determine the hereditary component of many diseases, as well as improve our ability to predict susceptibility to disease, onset and progression of disease, and response to medications. This increase in genetic knowledge has resulted in a gradual shift from genetics to genomics. Genetics is the study of individual genes and their effect on relatively rare single gene disorders, whereas genomics is the study of all the genes in the human genome together, including their interactions with each other, the environment, and the influence of other psychosocial factors and cultural factors. Genetic disorders affect people of all ages, from all socioeconomic levels, and from all racial and ethnic backgrounds. Genetic disorders affect not only individuals but also families, communities, and society. Advances in genetic testing and genetically based treatments have altered the care provided to affected individuals. Improvements in diagnostic capability have resulted in earlier diagnosis and enable individuals who previously would have died in childhood to survive into adulthood. Because the potential impact on families and the community is significant, genetic information, technology, and testing must be incorporated into healthcare services. Genetics must be integrated into nursing education and practice. The expanded roles for nurses with expertise in genetics and genomics are developing in many areas of maternity and women's health nursing. These areas include preconception counseling and testing, neonatal genetic screening and testing, palliative care for infants with life-threatening genetic conditions and their families, the identification and care of individuals with genetic conditions and their families, and the care of women with genetic conditions who require specialized care during pregnancy, such as women with congenital heart disease, cystic fibrosis, and factor V laden. Nearly 50 organizations, including the Association of Women's Health, Obstetric and Neonatal Nurses, or AWON, and the National Association of Neonatal Nurses, NAN, have endorsed the Essentials of Genetic and Genomic Nursing Competencies, Curricula Guidelines, and Outcome Indicators. The competencies in the document reflect the minimum amount of genetic and genomic competency expected of all nurses. Some of the competencies most relevant to nurses in maternity nursing include: constructs a pedigree from collected family history, information using standardized symbols and terminology, develops a plan of care that incorporates genetic and genomic assessment information, provides patients with credible, accurate, appropriate, and current genetic and genomic information, resources, services, and/or technologies that facilitate decision making, recognize when one's attitudes and values related to genetic and genomic science may affect care provided to patients, facilitates referrals for specialized genetic and genomic services for patients as needed, and evaluates the impact and effectiveness of genetic and genomic technology, information, interventions, and treatments on patients' outcomes. Most of the genetic tests now being offered in clinical practice are tests for single gene disorders in patients with clinical symptoms or who have a family history of a genetic disease. Some of these genetic tests are prenatal tests or tests used to identify the genetic status of a pregnancy at risk for a genetic condition. Current prenatal testing options include maternal serum screening, which is a blood test used to see if a pregnant woman is at increased risk for carrying a fetus with a neural tube defect or chromosomal abnormalities such as Down syndrome, trisomy 18, and trisomy 13. Fetal ultrasound or sonogram, and invasive procedures such as amniocentesis and chronic chorionic villus sampling, which we'll talk about later. Some disorders appear more often within certain ethnic groups, such as Tay-Sachs disease, which is more prevalent in Ashkenazi Jews, your beta thalassemias, which are more often occurs in Mediterranean, people of Mediterranean descent, your sickle cell, which is more often in African Americans, and cystic fibrosis, which is mostly seen in Eastern Europeans or Caucasians. Chromosomal abnormalities are a major cause of reproductive loss, congenital problems, and gynecologic disorders. The incidence of abnormalities is approximately 0.6% in newborns, 6% in stillbirths, and 60% in spontaneous abortions. Errors resulting in chromosomal abnormalities can occur in mitosis or meiosis. These errors can occur in either the autosomes or the sex chromosomes. Even without the presence of obvious structural malformations, small deviations in chromosomes can cause problems in fetal development. The most common trisomy abnormality is Down syndrome. Approximately 1 in every 691 newborns has Down syndrome. There are over 400,000 individuals with Down syndromes living in the United States. 95% of individuals with Down syndrome have trisomy 21. Although the risk for having a child with Down syndrome increases with maternal age, children with Down syndrome can be born to mothers of any age. 80% of children with Down syndromes are born to mothers younger than 35 years. The risk for a mother having a second child with Down syndrome is about 1% when the cause of Down syndrome is trisomy 21. Other autosomal trisomies that maternity nurses might see are trisomy 18 and trisomy 13. Trisomy 18 is more common than 13. It occurs in about 1 of 3,000 live births versus 1 of 10,000 live births for trisomy 13. Infants with trisomy 18 and trisomy 13 usually have severe to profound intellectual disabilities. Although both conditions have a poor prognosis, with the vast majority of affected infants dying before they reach their first birthday, a growing number of infants with these trisomies are living longer, and a small number are actually living into their 40s and 50s. Trisomy 21 or Down syndrome babies, which is the picture of the baby on this slide, have a distinctive physical appearance, including a peculiar line pattern in the palm of their hand called the simian crease. They are usually cognitively challenged to some degree, and there is a wide range from educatable to profoundly affected. Other signs that you may see in Down syndrome babies are low set ears, and they usually also have thicker tongues. This image is of chromosomes during cell division. Picture A is an example of photomicrograph. Picture B, chromosomes arranged in a karyotype with female and male sex determining chromosomes. Unifactorial inheritance. If a single gene controls a particular trait or disorder, its pattern of inheritance is referred to as unifactorial, Mendelian, or single gene inheritance. The number of single gene disorders far exceeds the number of chromosomal abnormalities. Potential patterns of inheritance for single gene disorders include autosomal dominant, autosomal recessive, and X-linked dominant and recessive models of inheritance. Multifactorial inheritance. Most common congenital malformations results from multifactorial inheritance, a combination of genetic and environmental factors. Examples are cleft lip, cleft palate, congenital heart disease, neural tube defects, and pyloric stenosis. Each malformation can range from mild to severe depending on the number of genes for the defect present or the amount of environmental influence. Some malformations occur more often in one sex. For example, pyloric stenosis and cleft lip are more common in males, and cleft palate is more common in females. Several sex chromosome abnormalities are caused by non-disjunction through gametogenesis in either parent. The most common deviation in females is Turner syndrome or monosomy X. The affected female exhibits juvenile external genitalia with undeveloped ovaries. She is short in stature and often has webbing of the neck, a low hairline on the back, low set ears, and lymphedema of her hands and feet. Intelligence may be impaired. Most affected embryos miscarry spontaneously. In most cases of Turner syndrome, it is the paternal X or Y that is lost. The most common deviation in males is Klinefelter syndrome or trisomy XXY. The affected male has poorly developed secondary sexual characteristics and small testes. He is infertile, usually tall and effeminate, and may be slow to learn. Males who have mosaic Klinefelter syndromes may be fertile. Genetic counseling. It is standard practice in obstetrics to determine whether a heritable disorder exists in a couple or in anyone in either of their families. The goal of screening is to detect or define risk for disease in low-risk populations and identify those for whom diagnostic testing may be appropriate. A nurse can obtain a genetic history using a questionnaire or checklist like the one in Figure 6-3, which is in your textbook. Estimation of risk. Most families with a history of genetic disease want an answer to the following question. What is the chance that our future children will have this disease? Because the answer to this question may have profound implications for individual family members and the family as a whole, healthcare professionals must be able to answer this question as accurately as they can in a timely manner. In some cases, estimation of risk is rather straightforward. In other cases, it is complicated. The role of the nurse in genetics. Nurses play many roles in genetics. Some nurses play a key role in the identification of families in need of genetic counseling, and they collaborate with other healthcare professionals to make referrals to specialists in genetics. Other nurses take a more active role in genetic counseling. Probably the most important of all nursing functions is to provide emotional support during all aspects of the counseling process. Feelings that are generated under the real or imagined threat posed by a genetic disorder are as varied as the people being counseled. Responses may include a variety of stress reactions such as apathy, denial, anger, hostility, fear, embarrassment, grief, and loss of self-esteem. Guilt and self-blame are universal reactions. It is up to the nurse to provide the emotional support that these families need during this time. Pregnancy lasts approximately 10 lunar months, 9 calendar months, 40 weeks, or 280 days. The length of pregnancy is computed from the first day of the last menstrual period until the day of birth. Primary germ layers. During the third week after conception, the embryonic disc differentiates into three primary germ layers: the ectoderm, the mesoderm, and the endoderm. All tissues and organs of the embryo develop from these three layers. The ectoderm, or the upper layer of the embryonic disc, gives rise to the epidermis, glands, nails, and hair, central and peripheral nervous systems, lens of the eyes, tooth enamel, and floor of the amniotic cavity. The mesoderm, the middle layer, develops into the bones and teeth, muscles, dermis and connective tissue, cardiovascular system and spleen, and the urogenital tract. The endoderm, or the lower layer, gives rise to the epithelium lining the respiratory tract and digestive tract, including the oropharynx, liver and pancreas, urethra, bladder, and vagina. The endoderm forms the roof of the yolk sac. The stage of the embryo lasts from day 15 until approximately 8 weeks after conception, when the embryo measures approximately 3 centimeters from crown to rump. The embryonic stage is the most critical time in the development of the organ systems and the main external features. The membranes. At the time of implantation, two fetal membranes that will surround the developing embryo begin to form, and these are the amnion and the chorion. The amniotic fluid, it serves numerous functions, and the volume is important to fetal well-being. The amount of fluid increases weekly, and 700 to 1,000 milliliters of transparent liquid is normally present at term. The volume of amniotic fluid changes constantly. The fetus swallows fluid, and fluid flows into and out of the fetal lungs. Beginning in week 11, the fetus urinates into the fluid, increasing its volume. The volume of amniotic fluid is an important factor in assessing fetal well-being. Having less than 300 milliliters of amniotic fluid, also known as oligohydramnios, is associated with fetal renal abnormalities. Having more than 2 liters of amniotic fluid, called hydramnios, is associated with gastrointestinal and other malformations. The yolk sac, it becomes the primitive digestive system. The yolk sac aids in transferring maternal nutrients and oxygen, which have diffused through the chorion to the embryo. The umbilical cord supplies the embryo with maternal nutrients and oxygens. There are 3 vessels in the umbilical cord. There are 2 arteries which carry blood from the embryo to the chorionic villi, and 1 vein which returns blood to the embryo. When you're thinking about the vessels in the cord, the acronym I like to use is AVA, 2 arteries, 1 vein. This is an image of a term placenta. Picture A shows the maternal or uterine surface, showing cotyledons and grooves. We call this side the dirty Duncan. This is the side that is attached to the uterus. B, or the fetal surface, showing blood vessels running under the amnion and conversion to form umbilical vessels at attachment of the umbilical cord. You can see all the vasculature here that's going to the cord. We call the fetal surface of the placenta the shiny Schultz. And then in C, you see the amnion and smooth chorion are arranged to show that they are 1 fused and 2 continuous with margins of the placenta. So this is the sac where the baby is encased in while in utero. The placenta is a very important structure. You will always hear me talk about the placenta as being my baby's lifeline. The placenta begins to form at implantation. During the 3rd week after conception, the maternal placental embryonic circulation is in place by day 17 when the embryonic heart starts beating. Functions of the placenta. One of the early functions of the placenta is as an endocrine gland that produces 4 hormones necessary to maintain the pregnancy and support the embryo and fetus. The protein hormone HCG, or human chorionic gonadotrophin, can be detected in the maternal serum by 8 to 10 days after conception, shortly after implantation. This hormone is the basis for pregnancy tests. The HCG preserves the function of the ovarian corpus luteum, ensuring a continued supply of estrogen and progesterone needed to maintain the pregnancy. The other protein hormone produced by the placenta is human chorionic somatotrophin, or human placental lactogen, or HPL. This substance is similar to a growth hormone and stimulates maternal metabolism to supply needed nutrients for fetal growth. HCS, or HPL, increases the resistance to insulin, facilitates glucose transport across the placental membrane, and stimulates breast development to prepare for lactation. We will talk more about HPL when we talk about gestational diabetes, so keep that in the back of your mind. The placenta eventually produces more of the steroid hormone progesterone than the corpus luteum does during the first few months of pregnancy. Progesterone maintains the endometrium, decreases the contractility of the uterus, and stimulates maternal metabolism and development of breast alveoli. Progesterone is a very important hormone during pregnancy because progesterone maintains the pregnancy. Estrogen, on the other hand, stimulates uterine growth and uteroplacental blood flow. It causes a proliferation of the breast glandular tissue and stimulates myometrial contractility. Placental estrogen production increases greatly towards the end of pregnancy. One theory for the cause of onset of labor is the decrease in circulating levels of progesterone and the increased levels of estrogen at the end of the pregnancy. The metabolic functions of the placenta are respiration, nutrition, excretion, and storage. Carbohydrates, proteins, calcium, and iron are stored in the placenta for ready access to meet fetal needs. Like I said, the placenta is my baby's lifeline. The placenta does everything for the baby. The baby has to do nothing while in utero. The placenta takes care of the baby. So when there are problems with the placenta, guess who gets affected? My baby. Fetal maturation. The stage of the fetus lasts from 9 weeks until the pregnancy ends. When we speak of viability, viability refers to the capability of the fetus to survive outside the uterus. With modern technology and advances in maternal and neonatal care, infants who are 22 to 25 weeks of gestation are now considered to be on the threshold of viability. Limitations for the baby surviving outside of the uterus are based on the central nervous system function and oxygenation capability of the lungs. The fetal circulatory system. The cardiovascular system is the first organ system to function in the developing human. Blood vessels and blood cell formation begins in the 3rd week and supplies the embryo with oxygen and nutrients from the mother. Respiratory system. The fetal lungs do not function for respiratory gas exchange, so a special circulatory pathway, the ductus arteriosus, bypasses the lungs. The respiratory system begins development through an embryonic life and continues through fetal life and into childhood. Pulmonary surfactants. The detection of the presence of pulmonary surfactants, surface active phospholipids, in amniotic fluid has been used to determine the degree of fetal lung maturity or the ability of the lungs to function after birth. Lecithin is the most critical alveolar surfactant required for postnatal lung expansion. It is detectable at approximately 21 weeks and increases in amount after week 24. Another pulmonary phospholipid, sphygmomyelin, remains constant in the amount. Thus, the measure of lecithin in relation to sphygmomyelin, or the LS ratio, is used to determine fetal lung maturity. When the LS ratio reaches 2:1, the infant's lungs are considered to be mature. This occurs at approximately 35 weeks of gestation. However, in some newborns, especially infants of diabetic mothers, the process of fetal lung maturity happens a lot slower, so their lungs may not be mature at the 35-week mark. So what we do for our women who are diabetic, or if anyone is at risk of preterm labor, what the obstetrician could do is they can do an amniocentesis, collect some of the amniotic fluid, send it for an LS ratio just to see if the lungs are mature. And usually for our diabetic mothers, if we think the baby is going to be ginormous or macrosomic, we will do an amniocentesis to see if the lungs are mature. If the lungs are mature, they can opt to deliver the baby before the baby gets any bigger. The hematopoietic system. Hematopoiesis, or the formation of blood, occurs in the yolk sac beginning in the 3rd week. The antigenic factors that determine blood type are present in the erythrocyte soon after the 6 weeks. For this reason, the Rh-negative woman is at risk for isoimmunization in any pregnancy that lasts longer than 6 weeks after fertilization. And we will talk about Rh-negative moms later on. The GI system. The fetus swallows amniotic fluid beginning in the 5th month. Gastric emptying and intestinal peristalsis occur. Fetal nutrition and elimination needs are taken care of by the placenta. As the fetus nears term, fetal waste products accumulate in the intestines as dark green to black tarry meconium. Meconium is the baby's first stool. Normally, this substance is passed through the rectum within 24 hours of birth. Sometimes with a breech presentation or fetal hypoxia, meconium is passed in utero into the amniotic fluid. The renal system. The kidneys form during the 5th week and begin to function approximately 4 weeks later. Urine is excreted into the amniotic fluid and forms a major part of the amniotic fluid. Oligohydramnios, which is too little fluid, is indicative of renal dysfunction. Because the placenta acts as the organ of excretion and maintains fetal water and electrolyte balance, the fetus does not need functioning kidneys while in utero. At birth, however, the kidneys are required immediately for excretory and acid-base regulatory functions. The neurologic system. Awareness. Fetuses respond to sound by 24 weeks. Different types of music evoke different movements. The fetus can be soothed by the sound of the mother's voice. Acoustic stimulation, which I will talk about later, can be used to evoke a fetal heart response. The fetus becomes accustomed to noises heard repeatedly, and hearing is fully developed at birth. This is a schematic illustration of the fetal circulation. We won't talk too much about fetal circulation because you do get it in the pediatric portion. Just know that at birth, when we clamp that cord, the foramen ovale, the ductus arteriosus, all of those things that were kind of like bypassed so that the lungs didn't have to work, um, those close, and then fetal circulation turns into regular normal circulation. So you'll get more about fetal circulation in the pediatric portion. Fetal maturation continued. The cells of the superficial layer are sloughed and become mixed with the sebaceous gland secretions to form the white, cheesy vernix caseosa. Vernix caseosa is the material that protects the skin of the fetus. The vernix is thick in the earlier parts of pregnancy, and as the pregnancy progresses to term, the vernix is very thin, or sometimes there's no vernix at birth. Very fine hairs called lanugo appear first at 12 weeks on the eyebrows and upper lip. By 20 weeks, they cover the entire body. At this time, the eyelashes, eyebrows, and scalp hair are beginning to grow. By 28 weeks, the scalp hair is no longer than the lanugo, which thins and may disappear by term gestation. Immunity. During the third trimester, albumin and globulin are present in the fetus. The only immunoglobulin that crosses the placenta is IgG. It provides passive acquired immunity to specific bacterial toxins. IgA is not produced by the fetus. However, colostrum, the precursor to breast milk, contains large amounts of IgA and can provide passive immunity to the neonate who is breastfed. The normal term neonate can fight infection, but not as effectively as an older child. The preterm infant, however, is at much greater risk for infection because these immunoglobulins have not been passed to the preterm infant. I like to tell a lot of my new moms, especially the ones that are breastfeeding and the ones who aren't breastfeeding, I try to encourage them by telling them the foremilk or the colostrum is full with antibodies that the mom has. And if they breastfeed these babies, at least give them the colostrum. It's like giving their babies their first set of immunizations without having to get poked with the needle. Sometimes it sells, sometimes it doesn't. But I always push for moms to breastfeed. Multi-fetal pregnancies. Twins. Dizygotic twins occur when two mature ova are produced in one ovarian cycle. Both have the potential to be fertilized by separate sperm. This results in two zygotes or dizygotic twins. There are always two amnions, two chorions, and two placentas that may be fused. These dizygotic or fraternal twins may be the same sex or different sexes and are genetically no more alike than siblings born at different times. Your monozygotic twins are identical twins. They develop from one fertilized ovum which then divides. They are the same sex and have the same genotype. If division occurs soon after fertilization, two embryos, two amnions, two chorions, and two placentas that may be fused will develop. Most often, division occurs between 4 and 8 days after fertilization. Other multifetal pregnancies. The occurrence of multifetal pregnancies with 3 or more fetuses has increased with the use of fertility drugs and in vitro fertilization. Triplets occur about 1 of every 1,341 pregnancies. This image depicts the formation of dizygotic twins. There is fertilization of 2 ova, 2 implantations, 2 placentas, 2 chorions, and 2 amnions. This is a placenta of diamniotic, dichorionic, separate twin placentas. So these placentas were not fused. You can actually see that there are 2 separate placentas, 2 separate umbilical cords. Non-genetic factors influencing development. Congenital disorders may be inherited or may be caused by environmental factors or by inadequate maternal nutrition. Congenital means that the condition was present at birth. Some congenital malformations may be the result of teratogens, that is, environmental substances or exposures that result in functional or structural disability. In contrast to other forms of developmental disabilities, disabilities caused by teratogens are theoretically totally preventable. Known human teratogens are drugs and chemicals, infections, exposure to radiation, and certain maternal conditions such as diabetes and PKU. A teratogen has the greatest effect on the organs and parts of an embryo during its period of rapid growth and differentiation. This occurs during the embryonic period, specifically from days 15 to 60. During the first 2 weeks of development, teratogens either have no effect on the embryo or have effects so severe that they cause miscarriage. In addition to genetic makeup and the influence of teratogens, the adequacy of maternal nutrition influences development. The embryo and fetus must obtain the nutrients they need from the mother's diet. They cannot tap the maternal reserves if there are no reserves. Malnutrition during pregnancy produces low birth weight newborns who are susceptible to infection. Malnutrition also affects brain development during the later half of gestation and can result in learning disabilities in the child. Inadequate intake of folic acid is associated with neurotube defects, which we will talk about more when we talk about maternal nutrition. Question: a woman is 8 months pregnant. She tells the nurse that she knows her baby listens to her, but her husband thinks she is imagining things. The most appropriate response by the nurse is: A. Many women imagine what their baby is like. B. Babies in utero do respond to their mother's voice. C. You'll need to ask the doctor if the baby can hear yet. Or D. Thinking that your baby hears will help you bond with the baby. If you answered B, you are correct. Feedback: A. Option A, which is incorrect. Although this statement is accurate, it is not the most appropriate response. Option B, which is correct. Fetuses responds to sound by 24 weeks. The fetus can be soothed by the sound of the mother's voice. Option C is incorrect. This statement is not appropriate. The mother should be instructed that her fetus can hear at 24 weeks and can respond to the sound of her voice. Option D is incorrect. This statement is not appropriate. It gives the impression that her baby cannot hear her. It also belittles the mother's interpretation of her fetus's behavior. Key points. Genetic disease affects people of socioeconomic levels and racial and ethnic backgrounds. Genetic disorders span every clinical specialty. Nurses with advanced preparation are assuming roles in genetic counseling. And we know that genes are basic units of heredity responsible for human characteristics. There are 23 pairs of chromosomes, 22 pairs of autosomes, and 1 pair of sex chromosomes. Normal pregnancy gestation is 28 days after the last menstrual period, or 10 lunar months, or 9 calendar months. Critical periods in human development during which embryo fetus is vulnerable to environmental teratogens, especially during the first 8 weeks of pregnancy, when fetal development of the major organ systems are taking place. This concludes the audio lecture for Chapter 6, Genetics, Conception, and Fetal Development. Thank you.